You are probably taking a breath right now without even, thinking about it.
Right, it's totally automatic.
Yeah, breathing is just this quiet engine running in the background of your life.
Yeah.
That is, until the terrifying moment your airway decides to shut down.
Oh, absolutely.
Suddenly, drawing a single breath becomes literally the only thing in the entire world that matters.
I mean, it is arguably the most primal panic a human being can experience. And, for hundreds of millions of people globally who live with asthma or chronic obstructive pulmonary disease, COPD, that threat isn't just some bad nightmare.
Right.
It is a constant, lingering reality they have to navigate every single day.
Which brings us to the focus of today's deep dive. We are talking about inhaled corticosteroids, or ICS.
The everyday inhalers.
Exactly. Those tiny engineered molecules inside those familiar inhalers you see everywhere, the ones designed to suppress chronic lung inflammation. Our mission today is to truly unpack the science here.
Yeah, to really look under the hood.
Right, we want to understand how these drugs completely revolutionize pulmonary medicine, how they actually rewrite your cellular biology, and, why using them is far more complex than just, taking a puff and getting on with your day.
Because the perception is usually that it's just this simple spray that magically opens your lungs.
Right.
But the pharmacology beneath it and the history of how we even got here, it's this fascinating story of chemical engineering trying to essentially outsmart human anatomy.
It really is. And to visualize this before we get into the weeds, think of an asthma attack, like a flash fire in a house.
Okay, a flash fire.
Yeah. Today, we are not focusing on the emergency fire extinguisher you grab when the kitchen is actively, engulfed in flames. We are examining the daily fire retardant spray you apply to the walls to keep the house from catching on fire in the first place.
That framing is so crucial. And to truly appreciate that daily fire retardant spray, we kind of have to look at the medical landscape before the inhaler even existed.
Right, because things were pretty bad back then.
Oh, the reality of treating severe asthma in the mid-20th century was incredibly grim.
You might be wondering, we have a pill for almost everything else, so why engineer a complex spray device just for this? Why couldn't doctors in the 1950s just prescribe a daily anti-inflammatory pill?
Well, they did.
Oh, they did.
Yeah, the primary treatment for severe asthma back then was oral corticosteroids. Drugs like prednisolone.
Okay.
They are these incredibly powerful drugs that mimic cortisol, which is the body's natural stress hormone. And to be totally fair to the doctors at the time, those pills were miraculous at stopping asthma attacks.
Right, so they actually worked.
They worked perfectly. The problem was the delivery method.
The pills themselves.
Exactly, because when you swallow a pill, that steroid is acting systemically. It's absorbed through your digestive tract and circulated everywhere, like in your entire body.
So using the analogy, the fire retardant is basically flooding the entire neighborhood, not just the kitchen that's at risk.
Which causes just massive collateral damage. The side effects of systemic steroids were devastating for patients who had to take them every day.
What kind of side effects are we talking about?
We're talking about severe weight gain, the total suppression of the body's natural adrenal glands, dangerous bone thinning, cataracts, yeah. And the most tragic effect was actually in children, where daily oral steroids literally stunted their physical growth.
Wait, really? It stopped them from growing?
Yes. Physicians were trapped in this terrible bind. They were effectively trading one chronic, life-threatening disease for another.
Because the anti-inflammatory punch was clearly there, but destroying the patient's long-term health to keep them breathing that wasn't sustainable.
Not at all. And it drove pharmaceutical chemists on this 2-decade search for a workaround.
He needed a better delivery system.
Right. They needed a way to get the immense power of a glucocorticoid directly to the airway tissue without dosing the entire body and causing all that systemic toxicity.
Which sets the stage for a massive breakthrough. The sources highlight this pharmaceutical company called Allen & Hanbury's in the UK, led by a researcher named Sir David Jack.
Yeah, Sir David Jack and his team. They realized that the solution wasn't necessarily finding a totally new drug, but hacking the body's own metabolic filtration system.
Hacking it how?
Well, they set out to engineer a highly specific corticosteroid molecule. First, it had to be incredibly potent locally, meaning you only needed a microscopic amount, literally a microgram, to control the airway inflammation.
Okay, so super concentrated.
Exactly. But the real stroke of genius was designing it to be highly susceptible to what we call first-pass metabolism.
First pass metabolism. Okay, let's
Very.
break that down because this sounds like the secret sauce.
It absolutely is.
Yeah.
So when you swallow anything, food, a poison, a pill, it gets absorbed through your gut and goes straight to the liver before it's even allowed to enter the main bloodstream.
Right, the liver filters everything.
Yes, the liver is the body's chemical filtration plant. So Jack's team engineered a drug that the liver would aggressively recognize and just tear apart on that very first pass.
So if a patient inhales the drug, the medication coats the lungs and does its job perfectly.
Right.
But if they accidentally swallow some of the spray, which, I mean, happens every time you use an inhaler, it goes down in the stomach, gets absorbed, and heads straight to the liver.
And the liver instantly dismantles it. By having the liver rapidly inactivate whatever was swallowed, they sharply limited how much of the active drug could ever reach the rest of the body.
That's incredibly clever.
They ended up with a drug called biclomethasone dipropionate.
And the sources mention a London physician, T.J.H. Clark, who finally proved this actually worked in humans. This was in a 1972 study in The Lancet, right?
That's the one. He showed that patients completely dependent on those dangerous oral steroid pills could just switch to this aerosolized biclomethasone.
And it worked.
It worked beautifully. They controlled their asthma, stopped taking the pills, and basically escaped the worst of the side effects.
I mean, it relied entirely on exploiting our anatomical delivery and metabolic clearance.
Yeah, you separate the therapeutic site of action, the lungs, from the toxic site of action, which is the rest of the body.
Right.
And because the drug had such a massive affinity for the body's receptors, tiny inhaled doses in micrograms were suddenly replacing oral pills measured in milligrams.
Wow.
That is a 1,000-fold difference in scale.
It is brilliant pharmacological engineering. You essentially figure out how to sneak the drug into the VIP section, the lungs.
I love that. Yes.
And meanwhile, you ensure any drug that accidentally stumbles into the main club, the digestive tract, is immediately thrown out by the liver's bouncers.
Exactly. The liver acts as the bouncer, neutralizing the threat before it can cause systemic chaos.
Okay, so now that we know how they got the drug safely into the lungs, let's zoom in even closer. Like, what is this tiny molecule actually doing once it lands on the airway tissue?
For that, we have to look at the first principles of cell biology. Corticosteroids are lipophilic.
Meaning they like fat.
Right. And since our cell membranes are basically made of a lipid bilayer, essentially a layer of fat, the steroid molecule doesn't need a special channel or like a transport doorway to get inside the cell.
Oh, really?
Yeah, it just effortlessly diffuses right through the outer wall of the airway tissue cells.
It just goes through the wall.
It totally goes through the wall. Once it's inside the cell's fluid, the cytoplasm, it encounters this specific protein called the glucocorticoid receptor.
Okay.
The steroid binds to it, and the two lock together. This newly formed steroid receptor complex then travels straight into the nucleus of the cell, where your DNA is stored.
And what happens in the nucleus?
Once inside, it executes two main maneuvers: transactivation and transrepression.
Transactivation and transrepression.
Okay.
Turning things on and turning things off. Let's start with what it turns on.
So transactivation is where this complex binds to specific DNA sequences and acts like a switch, turning on the genes that produce anti-inflammatory proteins.
Right.
It ramps up the body's natural peacekeeping chemicals, which actively dampen down inflammatory signaling cascades.
Turning on the peacekeepers makes perfect sense. But the sources noted that transrepression, the shutting down of signals, is actually the heavy lifter here at typical medical doses.
It really is.
So how does a steroid physically stop an inflammatory response?
It physically runs interference. See, in a cell experiencing an asthma trigger, there are pro-inflammatory transcription factors, essentially master switches that want to turn on genes to release chemical alarm bells.
Okay, so the alarm bells are ringing.
Right, and these alarm bells recruit inflammatory white blood cells, cause mucus glands to overgrow, and make the airway swell up and become super hyperreactive to things like cold air.
Which is the asthma attack.
Exactly. But in transrepression, the steroid complex physically blocks those master switches from ever binding to the DNA in the first place.
Wait, so if inflammation is a rowdy concert, turning on the anti-inflammatory genes is like handing the microphone to the peacekeepers.
Right.
But transrepression? The physical blocking of those master switches is basically like putting a parking boot on the hype men's cars so they can't even drive to the venue to start the riot.
Ha! I really love that visual. Because the hype men never arrive, the concert stays completely calm, the chemical alarm bells never ring, the white blood cells aren't recruited, and the swelling just recedes at its genetic root.
I mean, the biological design sounds so elegant. Keep the drug local, avoid the rest of the body, and literally rewrite the genetic signaling.
It sounds perfect, doesn't it?
It does. But human biology is rarely that neat and tidy. The liver bouncers you mentioned might be good, but if inhaled steroids were completely isolated to the lungs, there wouldn't be massive debates about their long-term use.
Yeah, that is a really crucial point. We have to clear up the misconception that inhaled means risk-free.
Right, because nothing is risk-free.
Exactly. The system isn't perfectly airtight. Some of the drug that coats the lungs eventually absorbs directly across the lung tissue and into the systemic bloodstream, completely bypassing the stomach and the liver.
Oh, so it sneaks past the bouncer.
It goes right out the back door. And over the years, clinical trials have proven that this systemic reach has real consequences.
Like the pediatric studies. If the drug is sneaking past the liver, what happens to children taking this every single day for years?
So the most famous study investigating this was the Childhood Asthma Management Program, or the CMP trial, published in the year 2000.
Okay.
They tracked 1,000 children with mild to moderate asthma, half received an inhaled steroid, budesonide, and half received a placebo.
And I'm guessing the asthma control was better with the steroid.
Oh, as expected, the asthma control in the steroid group was fantastic. However, the children on the inhaled steroid grew slower.
Wait, really?
Yeah. Their growth velocity dropped by roughly 1 centimeter during that first year of treatment alone.
A drop in growth velocity. That's exactly what the old pills used to do. Did the medical community assume this was just like a temporary delay, like maybe the kids would catch up once they hit puberty?
That was the desperate hope for over a decade. Pediatricians strongly theorized it was just a slight delay in the growth curve.
But it wasn't.
No. A follow-up study in 2012 tracked those exact same children into adulthood, and it found that the adults who had been given the inhaled steroid as children were, on average, 1.2 centimeters shorter than those who got the placebo.
Wait, if kids are permanently losing half an inch of adult height, how is that not a total failure of the original 1960s drug design?
Well, because it is the unavoidable tax of human biology. You have to weigh the alternatives, right?
Okay.
A permanent 1.2 centimeter loss in adult height is a real, measurable, systemic effect. But without that drug, many of those children would have suffered permanent lung remodeling from chronic inflammation.
Or worse.
Or potentially fatal asthma attacks. So the design didn't fail, it just reduced a catastrophic side effect to a manageable one. But that height loss is exactly why modern pediatric guidelines are fiercely adamant about stepping down to the absolute lowest effective dose for children.
You accept a slightly shorter adult because the alternative is unacceptable.
Right.
But that is in relatively healthy growing children. What happens when you introduce this potent immune suppressor into lungs that are already heavily damaged, like, older patients dealing with COPD?
The consequences look very different there, and it shocked the medical community again.
How so?
Well, COPD involves chronic lung damage, usually from smoking or environmental exposure. For a long time, doctors just assumed that if inhaled steroids reduced inflammation and saved lives in asthma, they would naturally do the exact same thing in COPD.
I mean, it seems like a logical leap. Inflammation is inflammation.
Right, so they ran the TORH trial in 2007. They gave COPD patients an inhaled steroid called fluticasone, fully expecting a clear, massive reduction in mortality.
And what happened?
It narrowly missed statistical significance for extending their lives. And worse, the data revealed a clear, undeniable increase in the risk of severe pneumonia for the patients on the steroid.
Wow. Giving a patient a lung medication that ends up causing a severe lung infection.
Yeah.
That feels incredibly backward.
It does, but it connects right back to the mechanism we just discussed. The drug is suppressing inflammation by blocking those genetic signals.
The transrepression.
Exactly. But inflammation isn't inherently evil. It's also how the local immune system fights off invading bacteria.
Oh, I see.
So by dampening down the inflammatory response so effectively in lungs that were already structurally compromised by COPD, the steroid effectively rolled out the red carpet for bacterial pneumonia to take hold.
So hearing all this, the stunted growth in kids, the pneumonia risk in adults, you might be wondering why we even bother with the steroids at all.
It's a fair question.
Right, because we have bronchodilators.
Huh?
Those are the rescue inhalers that just relax the smooth muscles and open the lung pipes back up. Why not just use those and skip the steroid entirely?
It is totally understandable to think that, but acting on it is incredibly dangerous. We have tragic clinical data showing exactly what happens.
Really?
Yeah. In 2006, a major study looked at asthma patients using long-acting beta agonists, which are powerful bronchodilators, without pairing them with an inhaled corticosteroid.
And if they just kept the lung pipes open, shouldn't they have been fine?
They weren't fine. The study found a small but highly significant increase in asthma-related deaths, and it was particularly pronounced in Black patients.
Wait, deaths? Just from keeping the airways open, what is the mechanism there?
It's because asthma actually has two components: the squeezing of the smooth muscle around the airway and the inflammatory swelling of the tissue inside the airway.
Okay, muscle squeeze and tissue swelling.
Right. A bronchodilator only treats the muscle squeeze. It forces the airway open, making the patient feel fantastic in the moment.
But the swelling is still there.
Exactly. The underlying cellular inflammation, the swelling, the mucus is still raging, totally unchecked. The disease is silently worsening behind the scenes. Eventually, the inflammation becomes so severe that it overwhelms the bronchodilator.
And then what?
When that flare-up finally breaks through, the airways swell shut entirely, and it is catastrophic.
Wow. Taking a bronchodilator without an inhaled steroid is basically taking the batteries out of your smoke alarm while your kitchen is actively on fire.
Yes.
The loud noise stops, so you feel better for a second, but you are masking a disaster that is actively destroying the house.
That analogy is spot on. You're turning off the warning signal without putting out the fire. The findings from that study were so stark that the FDA actually stepped in with a black box warning.
Oh, wow.
Yeah, strictly forbidding the use of those long-acting bronchodilators as a monotherapy for asthma. They must always be paired with a steroid to treat the root cause.
Which brings up this massive tension in pulmonary medicine that the sources really emphasize.
Mm.
There's this constant precarious tug of war between underusing the drug and overusing it.
Absolutely, and the context changes entirely depending on the disease.
How so?
Well, in asthma, the danger is underuse. Studies have shown that gaps in taking daily inhaled steroids lead directly to a higher risk of death. You absolutely need that daily fire retardant.
Right.
But in COPD, because of the pneumonia risk we just discussed, the drug has historically been overused. Modern guidelines for COPD now restrict inhaled steroids mainly to patients who have elevated blood eosinophils.
Meaning they only prescribe it if a blood test shows this COPD patient has a very specific type of inflammation, like one that actually mirrors asthma.
Exactly. We used to define the drug by where it worked the lungs. Now we define its use by what kind of cellular inflammation is actually present in the patient.
Which perfectly sets up how all this research, the height data, the pneumonia risks, the black box warnings, how it actually trickles down to the inhaler you might pick up at the pharmacy today.
Yeah, all of this led to one of the biggest paradigm shifts in respiratory medicine over the last half-century. For roughly 40 years, there's a strict, unbreachable wall in how asthma was treated.
The wall between the controllers and the relievers.
Exactly. You had your daily controller inhaler, which was your steroid, and you had your separate reliever inhaler, which was your short-acting bronchodilator for emergencies.
Two different devices, two completely different jobs.
But in the 2019 and 2020 international guidelines, that wall was completely smashed. Medical bodies introduced a strategy called smart single maintenance and reliever therapy.
Oh, smart.
Yeah. They took a combination inhaler containing both the inhaled steroid and a fast-acting bronchodilator and approved it to be used as both the daily maintenance drug and the instant rescue inhaler.
I mean, combining them makes logical sense. If you're having an asthma attack and you reach for a rescue inhaler, you should just be silencing the smoke alarm.
Right.
You should be getting a targeted blast of fire retardant at the exact moment your airways are flaring up.
Exactly. You get symptom relief and targeted disease control in a single puff. But, the secondary reason for this shift is purely behavioral. It dramatically simplifies the treatment. Managing two inhalers is complex, and poor adherence is a massive problem. And a lot of that is driven by what doctors call steroid phobia.
Oh, right. People hear the word steroid and their brain immediately jumps to illegal bodybuilding drugs or anabolic steroids.
Exactly. But anabolic steroids are derived from testosterone, and they drive muscle growth. Corticosteroids mimic cortisol and regulate inflammation.
So they're completely different.
They share a basic chemical backbone derived from cholesterol, but their effects on the human body couldn't be more different. So by simplifying the regimen into a single, highly effective device, you bypass a lot of that phobia and confusion.
So we've seen how understanding inflammation rewrote asthma and COPD guidelines, but the sources highlight a wild card from very recent history where this decades-old lung knowledge suddenly became globally relevant again.
Oh, the pandemic. Yeah. During the height of the COVID-19 pandemic, researchers at Oxford ran a trial to see if inhaled budesonide, just the standard everyday asthma steroid, could do anything for people who had just tested positive for the virus.
Was the theory just that, COVID attacks the lungs, so let's throw a lung drug at it?
It was actually more targeted than that. They understood that severe COVID was driven by an inflammatory overreaction in the airway tissue.
Oh, the cytokine storm.
Right. The steroid trial found that patients who used the inhaled steroid early in their infection had meaningfully fewer urgent care visits and actually recovered faster.
Wow.
The drug did exactly what it was engineered to do decades ago. It slipped into the cells, blocked the pro-inflammatory transcription factors, and just dampen the body's overreaction.
It is a great example of how understanding the base code of a disease, in this case, airway inflammation, can give us a massive head start when a totally novel virus attacks that exact same tissue.
Yeah, when we understand the core mechanics of how our cells communicate, that knowledge pays off in totally unexpected ways.
Bringing this all together, today we've uncovered how inhaled corticosteroids were engineered to solve the horrific side effects of 1950s steroid pills by basically using the liver as a metabolic bouncer.
Best bouncer in the body.
For sure. We learned how they slip into our cells to physically block the genes responsible for inflammation. We navigated the very real systemic risks, like height changes and pneumonia, and saw how pairing steroids with bronchodilators literally tore down a 40-year wall in modern medicine.
The evolution of this drug really is a triumph of pharmacology. And, if there's one final thought to ponder from all this research, it is the concept of the therapeutic index.
A therapeutic index.
Yeah, that index is simply the gap between a drug dose that heals you and a dose that harms you. The entire invention of the steroid inhaler was essentially a mechanical trick to widen that gap.
Right.
By using the lungs as a backdoor, they took a highly toxic pill and made it a daily lifesaver. It makes you wonder what other medical breakthroughs are waiting out there right now. Not by inventing a completely new drug, but simply by finding a much cleverer door into the human body.
That is a fascinating thought to leave on. Thank you for joining us on this deep dive. Next time you take a breath without even thinking about it, remember the decades of science working behind the scenes to keep that airway open. Keep questioning the world around you, and we will catch you on the next deep dive.